Bismillahirrahmanirrahim. This video is about cesarean scar, ectopic pregnancy, diagnostic challenges, and management option. Basically, this is the TOG articles which we will discuss in detail to discuss the important points. Okay, so key contents: incidence of the cesarean scar ectopic pregnancy is increasing because of the rising number of the cesarean section, and prompt diagnosis of the condition is required to reduce the associated morbidity. Okay, so that is the key content. Okay, so we will discuss one by one. Okay, second point is that a high index of suspicion is required for the woman with a suggestive history of cesarean scar ectopic, and ultrasound scan is a diagnostic tool of the choice, and management option include the medical and the surgical and interventional radiology. Appropriate patient selection is important for optimal results, and major hemorrhage and hysterectomy are the main risk associated with cesarean scar ectopic. Therefore, adequate counseling and availability of the surgical expertise and blood transfusion should be a part of the comprehensive management strategy. Now, learning objectives that understanding the clinical and ultrasound feature of cesarean scar pregnancy and distinguish these from the feature of other low implantation pregnancy, and learn about the available treatment options and the risk factor influencing the treatment choices. Be aware of the clinical issues associated with the diagnosis of the live cesarean scar pregnancy. Now, ethical issue. Okay, do women planning the subsequent pregnancy after a resolved cesarean scar pregnancy require surgery to close the uterine defect in the scar to prevent the recurrent scar ectopic pregnancy, or should the risk of cesarean scar pregnancy in the future be routinely discussed? Okay, so these are the things. Now, introduction. We have a lot of points written in the introduction, but let us discuss the highlighted point as estimates of cesarean scar pregnancy incidence ranges from 1 in 800 to 1 in 2500 of all pregnancy. It has been estimated that 6.1% of pregnancies in the women with at least one previous cesarean scar and a diagnosis of ectopic pregnancy will be cesarean scar pregnancy. Okay, so basically the incidence is 1 in 800 to 1 in 2500, is very rare form. Okay, so now let us discuss the pathophysiology. Pathophysiology is that little is known about the mechanism and etiology of the cesarean scar pregnancy. Endometrial and myometrial disruption or scarring should be the predisposing factor in the abnormal pregnancy implantation, and the most probable mechanism explaining scar implantation is the invasion by the implanting blastocysts through the microscopic tract that develops from the trauma of the earlier cesarean scar. Okay, the presence of a cesarean scar in the uterus may also inhibit the implantation of the gestational sac, secondary to the more global effect of prior surgery on the endometrium rather than just the physical presence of the scar. And the risk of the scar implantation might be proportional to the size of anterior uterine wall defect, possibly caused by the larger surface area induced by the scar. However, since most of the cesarean scar pregnancy occurs after only one previous cesarean section, there is no clear correlation between the risk of the cesarean scar pregnancy and the number of the previous cesarean section. Women who elect to have a cesarean section because of the breech presentation in the previous pregnancy appear to be most frequently at risk of future cesarean scar pregnancy. Okay, so if the question is asked that which type of presentation is the most important risk factor, that is the breech presentation, and this may be related to the need for the higher uterine incision because of the poorly formed lower segment. Okay, the reason behind this is that in case of the breech, the lower uterine segment is not properly formed, so there is a need for the high uterine incision. Okay, in the figure you can see the transvaginal image of the cesarean scar with a yolk sac and fetal pole. You can see that. Okay, recurrence is 3.2 to 5%. Most of the women have the normal pregnancy following cesarean scar pregnancy. The risk of the recurrence has been reported to be as 3.2 to 5% in the woman with a one previous cesarean scar pregnancy treated with a dilatation in curettage with or without uterine artery embolization. Factors associated with increased risk of the recurrence includes the lower segment thickness measuring less than 5 mm, gestational sac bulging into the uterovesical for cesarean delivery in the rural community hospital, and the history of the irregular vaginal bleeding and abdominal pain during the previous cesarean scar pregnancy. Theoretically, the surgical management with the closure of the defect to restore the normal anatomy should reduce the risk of the recurrence. However, the recurrence after the surgical repair has been reported. There is therefore scope for the more research to characterize the factors associated with the reduction in the recurrence of cesarean scar pregnancy in the women who have undergone the surgical repair of the uterine defect. Now, how would you diagnose that? Okay, and women with cesarean scar pregnancy may present with a slight vaginal bleeding and or abdominal discomfort. Incidental diagnosis later in the pregnancy is sometimes made in asymptomatic women. Rarely, women may present with acute pain and profuse vaginal bleeding. It is not uncommon to diagnose cesarean scar pregnancy during or after attempted surgical evacuation for the miscarriage. Hemodynamic instability and collapse in a suspected cesarean scar pregnancy strongly indicates the rupture with the intra-abdominal bleeding. Given the potential for the serious life-threatening complications, accurate and reliable diagnostic criteria are required. Now, coming to the imaging, ultrasound imaging is the main diagnostic tool for cesarean scar pregnancy. A combined transabdominal and transvaginal ultrasound scans has a high accuracy rate in the diagnosis of cesarean scar pregnancy. Key to the diagnosis of cesarean scar pregnancy has a high index of suspicion following an ultrasound assessment demonstrating characteristic features. A transabdominal pelvic ultrasound scans allows the panoramic view of the uterus and its relation to the bladder. It is particularly useful in the late gestation when a transvaginal scan may not provide a panoramic view. A typical feature of cesarean scar pregnancy, as revealed by the ultrasound, is the gestational sac attached to the scar of the previous cesarean section, either on the endometrial cavity side or completely embedded in the scar and surrounded by the myometrium. Its appearance varies depending upon the gestational ages. The yolk sac, embryo, and cardiac activity may be seen in the normal pregnancy. Okay. And a prominent and distinct circular vascular flow may be seen around the gestational sac using the color flow Doppler. Transvaginal 3D ultrasounds with a power Doppler may yield superior image, including the 3D image of the ectopic. It also identifies the peritrophoblastic vascular flow in the tissue surrounding the sac, and the measurement of the myometrial thickness is relatively higher. The 3D ultrasound is not routinely required but may complement 2D ultrasound finding if necessary, especially where the expertise is available. MRI is also useful adjunct for the diagnosis of cesarean scar pregnancy. MRI provides crucial information. Okay, now ultrasound criteria is that first of all there is the empty uterine cavity and the closed and empty cervical canal, and placenta or gestation sac embedded in the scar of the previous cesarean section, and a triangular, round and oval gestation sac fills the niche of this scar, and a thin or absent myometrial layer between the gestational sac and the bladder. Yolk sac, embryo, and cardiac activity may or may not be present. Evidence of the function trophoblastic placental circulation on the color flow Doppler examination characterized by the high velocity and low impedance flow, blood flow, negative sliding organ signs. Okay. So these are the things. Now, classification. Cesarean scar pregnancy can be classified into two main types based upon the imaging finding and the pregnancy progression. Type 1 or androgenic cesarean scar pregnancy is where the implantation occurs on the scar and the gestation sac grows toward the cervicoisthmic or uterine cavity. Type 2 or exogenic cesarean scar pregnancy occurs when the gestation sac is deeply embedded in the scar and surrounding the myometrium and grows towards the bladder. And in the exogenic type, a layer of the myometrium may be seen between the gestation sac and the bladder at an earlier stage, and this becomes thin and eventually disappear with the bulging of the gestational sac through the gap as the pregnancy progresses, and thus carrying a greater risk of the earlier rupture. In the 2/3 of the cases, the thickness of the scar may be less than 5 mm. Now, coming to the differential diagnosis, a published literature reveals that up to 13.6% of the cesarean scar pregnancies are misdiagnosed as earlier inevitable miscarriage with a low-lying scar or cervical pregnancy, a gestation sac lying low in the uterine cavity in the cervicoisthmic area or in the endocervix should be clearly differentiated from the cervical scar pregnancy and cervical ectopic pregnancy. Interventions such as surgical evacuation of a misdiagnosed case can lead to major hemorrhage resulting in a hysterectomy, and the earlier phase of the miscarriage can mimic Cesarean scar pregnancy. However, in an impending miscarriage, gestation sac is often irregular and located within the uterine cavity with the absent on minimum color Doppler flow, and gentle pressure at the level of the internal cervical os may displace the gestation sac, thus demonstrating what is known as the sliding sign. And the sliding sign is typically absent in cesarean scar pregnancy and cervical ectopic pregnancy. A cervical ectopic pregnancy is present in or close to the cervical canal and the ballooning of the cervix. Good color flow Doppler and negative sliding sign may be seen in the cervical pregnancy. In the later gestation, cesarean scar pregnancy may be missed if the gestation sac of an endogenous cesarean scar pregnancy grows towards the uterine cavity. MRI is useful for making reliable diagnosis in the cases of the uncertain clinical and ultrasound features. Now, management. There is no consensus on the preferred mode of the treatment for cesarean scar pregnancy cases, and several have reported different treatment modalities, which are shown in the box. Okay, so coming to the different treatment modalities. Management option for cesarean scar pregnancy: expectant use very rarely in the selected cases. A medical systemic methotrexate, local injection and embolization, local injection of methotrexate with a sac aspiration, and local injection of the other embryo sites uterine artery. Chemoembolization. Surgical management include dilatation and surgical evacuation, hysteroscopic resection, vaginal excision and resuturing, laparoscopic excision and resuturing, and open excision and resuturing, combined laparoscopic and hysteroscopic procedure, combined laparoscopic and vaginal surgery, hysterectomy. Now, combined or sequential management include uterine artery embolization / chemo embolization followed by dilatation and evacuation or surgical resection in 24 to 48 hours. Methotrexate followed by the surgical evacuation or resection after an interval. The factor influencing the management choices include, first of all, the patient factors, which includes the symptoms, fertility wishes, acceptability of the prolonged follow-up, and associated lesion and surgical risk factor and response to the initial treatment. Cesarean scar pregnancy includes the gestation sac, human chorionic gonadotrophin level, size of the cesarean scar pregnancy mass, and type of the cesarean scar pregnancy, myometrial thickness, and viability. The facilities includes interventional radiology and surgical expertise facilities, monitoring facilities. Okay, so it is written that there is no consensus on the preferred mode of the treatment for cesarean scar pregnancy. Cases and series have reported different treatment modalities, and there are several variables to consider before recommending a treatment option, and all the treatment options carry a risk of the hemorrhage and subsequent hysterectomy, and treatment should be individualized based on the full pre-treatment evaluation. In principle, the pregnancy should be ended as soon as possible after confirming the diagnosis with the aim of removing the gestational sac and cesarean scar pregnancy mass to retrain the future fertility. Now, coming to the medical management. Methotrexate is the drug of the choice for the medical management. Systemic administration of the methotrexate is commonly used alone to successfully resolve the human chorionic gonadotrophin level and cesarean scar pregnancy ectopic mass. In most of the cases, the methotrexate dose regime and the follow-up of the cesarean scar pregnancy is the same as that used for the tubal ectopic pregnancy. Prior to its administration, all the women receiving methotrexate should have a baseline for blood count and liver and renal function test. Adequate counseling should be provided regarding the likelihood of the prolonged follow-up, repeated HCG, and the need for the additional treatment doses and the possibility of the surgical intervention, including hysterectomy. Conservative medical management with the methotrexate is appropriate in hemodynamically stable cases with unruptured cesarean scar pregnancy, and a review of the cases in which cesarean methotrexate was used revealed that 41% results with no additional treatment required. However, this option is more likely to succeed where HCG level are lower than 5,000 international units and gestation age is less than 8 weeks. Methotrexate treatment, at least as initial treatment prior to the surgery, may be better option than the surgical treatment alone in the woman with exogenous type of cesarean scar pregnancy, which has minimal myometrial thickness and anticipated surgical complexity. Local injection and embolization. Local embryosides. Local injection of the various embryocidal agents have been used to treat cesarean scar pregnancy. Methotrexate is the commonest drug used, and other embryosides such as potassium chloride, etoposide, and hyperosmolar glucose have been also been used as a local administration. In this effective technique, the gestation sac is aspirated and methotrexate injected in it under the ultrasound guidance, and in a series of 11 cases treated by the sac aspiration and the local methotrexate injection, 54% of the women requires a further dose of systemic methotrexate with eventual complete resolution of cesarean scar pregnancy. Mass transabdominal and transvaginal injection approaches are both feasible. However, the transvaginal approach has the advantage of being anatopically closer to the target and so to help to avoid the visceral injury in the time required for the complete resolution of the ectopic pregnancy correlates with the initial sac size and HCG level. Now combine local and methotrexate administration. Gestational sac aspiration with administration of methotrexate into the sac combined with systemic administration of the methotrexate appears to have a better success rate and requires a fewer additional intervention. In a review of 17 reported cases by this person, 74% of the women treated with the combined methods require no further intervention. In this technique, the first full dose of the methotrexate is either injected directly into cesarean scar pregnancy or may be divided equally, with a half administered into cesarean scar pregnancy sac and other half given intramuscularly. Further doses required in the event of the inadequate reduction in HCG levels are given intramuscularly. Okay. Now, uterine artery chemoradiation. Uterine artery chemoembolization has been used in conjunction with the administration of systemic or local methotrexate and during or after surgical removal of cesarean scar pregnancy to prevent bleeding. Bilateral uterine artery chemoembolization with a gel foam and methotrexate has also been used as a treatment option. Okay, so just leave this data. And surgical management. Surgical evacuation, cervical dilatation and curettage is commonly used method of managing cesarean scar pregnancy. Surgical evacuation is suitable for endogenic cesarean scar pregnancy with a myometrial thickness of at least 12 mm. However, it varies. However, it carries the risk of the bleeding and may fail to remove all of the pregnancy sac residues in the scar tissue. It should therefore be performed under the guidance of ultrasound to aid the complete tissue removal. Various techniques to reduce the bleeding during and after surgical evacuations have been reported, and most of the cases series have reported the use of uterine artery embolization with the methotrexate, but other reported techniques include the use of the intrauterine Foley's catheter and Shirotka's sutures. A Shirotka's sutures applied prior to the surgical suction and evacuation and tied after the procedure is an effective method of reducing the bleeding following evacuation. It also avoids the risk of further interventions